Yes.
Can you please come to the side? The panel has started.
I'm saying so. We have 2 minutes. Okay, everybody's sharing. Yeah, because that just everybody's doing online. Everybody's doing it online. We can just leave that one. They'll check first. Yeah, the thing is difficult. Okay, so I'll just send you the email. Please can you confirm that email? Okay. This is not for. Well, I just sent it down now. Yes. One last piece. Good evening, everyone. Victor. We are welcome to the part 3 of this panel, Cultural, Social, and International Public Health in Africa, organized by Professor Adeyemi Ademobo, Tabala University, Muradike Badru Abiodun, Tabala University. We have 4 papers, but unfortunately 2 speakers are ready. So the 2 speakers, they have 20 minutes each to speak to their papers. The first paper, who is going to be the first? Okay. Okay. I'll speak. You want to begin, sir? Yes. Okay. Are you ready? Okay. And the title of this paper, Obani Koro, the King as Coronavirus, Legible Innovations and Cultural Dimensions of the COVID-19 Pandemic in Southwest Nigeria by Oluwaseek Oludude Obafemi. Sorry, Oludude Obafemi Awolowo University. 20 minutes.
Good evening, colleagues. Good evening, the facilitator. Although I say community from OEU, we call it Obaho University. So the title of my presentation is Obani Koro, the King as Coronavirus, Lexical Innovations and Cultural Dimensions of the COVID-19 pandemic in Southwest Nigeria. Obani Koro is actually a play on words. We are all familiar with Obani Koro. So it's a play on words, and I'm from the Department of Linguistics and African Languages. We play with language, and of course, we also play with culture. So the outline of presentation, the next slide, it's going to be a background to the study, research objectives and methodology, my conceptual framework, then data presentation and analysis, then conclusion, appreciation, and acknowledgement. Now the background to the study, the next slide. COVID-19 originated from in Wuhan, China in 2019. I'm sure we are familiar with that. The disease affected the entire globe, causing devastation, colossal damages everywhere. The record of deaths grew to over 6 million, with the US alone accounting for over 1 million deaths. Thereafter, several prevention protocols, of course, had to be brought in to checkmate the spread of the disease. Basically, the use of face masks, constant hand washing with soap or hand sanitizers, and the social distancing in public places. Then, at the point in time again, effort went into the production of vaccines. The next slide. Well, the effect of the pandemic was different in sub-Saharan Africa. That is what I'm trying to look at, especially in Nigeria. The effect was quite different. The death rate was remarkably low. Contrary to predictions by Melinda Gates, she actually, that was the wife of the former world richest man, Bill Gates. She predicted that dead bodies might litter the streets of Africa. That was her prediction. But of course, it never came to be. Never happened. So I was trying to look at how people reacted to the pandemic in diverse ways. Their religion was affected, their culture was touched, their philosophy, their art, music, and their language use patterns felt the impact of the pandemic. And of course, I'm looking at this from the language and cultural point of view. The Yoruba people of Southwest Nigeria had to brought up several humorous lexical innovations to capture their cultural background. One thing about the Yoruba people of Southwest Nigeria is when issues come, when challenges come, rather than crying or whatever, Yorubas will find a way of playing it down, and then bringing their culture and then just making fun of it. That is exactly what I try to do in this work. I try to look at several humorous lexical innovations that captured their cultural backgrounds, their feelings, their thoughts about COVID-19. Well, for the sake of time, I'm going to skip the next slide. The next slide.
30 minutes.
30 minutes.
Yes.
Oh, that's fine. So I should have.
No, that's 20 minutes. 20 minutes.
They're just two.
Yes, 20 minutes.
Okay. Yeah, thank you. So, what studies around language use during the COVID-19 pandemic focus on the reactions of people. Language is meant for expression, so people always react to COVID in diverse ways. And those expressions brought out their lived experiences about how they tackled COVID, their impression about COVID, their thoughts, and then their perceptions. But there are quite a number of research on this, pragmatic discourse analysis, massive use of internet memes, and so on and so on and so forth. Let me just move straight to the research objectives. The next slide, please. So this study examined the consequence of COVID-19 on existing words, expressions in the language, and in the Yoruba vocabulary, which convey their perceptions that the people have about COVID. Specifically, the objectives were one, to find answers to what are the naming strategies, the words, phrases, and statements in Yoruba that have taken on new or additional meanings in the aftermath of COVID-19. Two, how do the lexical innovations and punning strategies, pun means play on words, how do these strategies and amplify the cultural beliefs of the people of Southwest Nigeria about the COVID-19 pandemic? And then three, is it true that COVID-19 is an elitist disease in Southwest Nigeria, as exemplified by the punning of, and that's where I take my topic from, Obaniko, meaning the king has coronavirus. And I'm asking, is it true that only the kings, the leaders, the airlines can contract COVID-19? So these are the three objectives which I intend to find answers to. My methodology is a mixed methods approach. Questionnaires were administered both physically and then through online Google Forms. I conducted interviews with selected individuals on their views about COVID-19. Then participants, of course, I'm a participant during COVID. So I observed people's narrations and narratives about the pandemic experience. Then I also visited the African Center of Excellence for the Genomics of Infectious Diseases, ACG, That's in Redeemers University. And it's a very famous center. In fact, the center was it was the center that provided the first samples testing of COVID. So I met with the directors and then I had a conversation with them to find out the status of those that tested positive for COVID-19. Are they truly elite or a commoner? Any other person can contract COVID. Well, some of the data, the quantitative part was analyzed using SPSS, and then the qualitative part using content analysis through a sociolinguistic and a morphological point of view in order to bring out their views, cultural dimensions of COVID-19. Well, my framework is within what we refer to as corpus planning in linguistics. It's a language engineering kind of framework. Now, when you have new ideas, new concepts, language is dynamic, it's living, it's not dead, it's not static. So people come up with new words, new ideas to capture their feelings, capture their thoughts, and then even form words for words that never existed before. So it's within the framework of corpus planning, language expansionism. You expand the framework of language to capture new thoughts. COVID-19 never, of course, it's new, and so the language must adapt to that to capture the feelings and thoughts and cultures of the people. Well, some scholars refer to this as language engineering. So I say Yoruba people have a way of naming persons, naming places, naming situations, and it's captured under the concept we refer to as onomastics, explained in Ogunwale 2016. Part of my conceptual framework is a health belief model. This concept is likely predicted by 6 variables. And the major point of the theory is that people's perception, knowledge, and aware, if you are aware or you know you are at a risk of contracting a disease, the way you tackle it is going to be different. But if you have this lackadaisical kind of attitude, maybe you believe, well, COVID is for their needs, not for the man on the streets or the woman in the marketplace, then that actually affected their approach towards COVID. And it's a kind of cultural thing which health practitioners must begin to look at when, in case of future pandemics and, in fact, other kinds of diseases that come up. So the theory posits that the individual will weigh the benefits of the prevention or treatment of a disease, as well as the barriers before the individual takes actions. So it's important. So I say some of these thoughts came to the fore, and it's of course obvious in the lexical innovations that the people used in describing their pandemic experiences. So let me go straight to my data and then the analysis and then my findings. The next slide, please. So I said COVID-19, the lexical innovations and Yoruba naming strategies. Of course, COVID-19 came. It never existed in the Yoruba dictionary, in the Yoruba vocabulary, in the Yoruba language. So from the naming of the disease, that was where the cultural and then the kind of language engineering began. So Yoruba speakers began to look for words to name the disease. And the first one was people just called it Arukuru or simply Kuru. From there, Arukuru. Then I tried to look at Koro itself as a word, and I discovered Koro is a word that has taken on additional meaning. Koro existed in Yoruba. For instance, if I say Osoju Koro, so it's a word that on its own meaning, like yes, I saw it going. I was. It was obvious I saw it. But now Koro is also Koro is different when people now say Arun Koro for the naming of the disease, which is the kind of adaptation we needed to adapt to the existence of COVID. So Koro is a word that took on additional meaning. And then Koro normally is an adverb that emphasizes the fact that one witnessed an event. But here, Yoruba people conveniently named the disease Arun Koro. Imagine there was no word for that in Yoruba. Then how would the doctors, how the medical people try to approach this concept. So your koro is a clipped form of corona. Actually, koro is from corona, which is through clipping, by clipping out the part and then leaving just koro. Several other names were given to COVID-19 by Yoruba speakers. Majority apply the concept in Yoruba. There is a concept of borrowing. When you don't have a word, you need to borrow, and it's a concept in language generally. There is a ear loan, there is a eye loan, which we call them aphetia, and then aphetia, something like that. So people gave the word COVID. That's from the word COVID itself, or some called it COVID-19. Now, COVID itself, it's a kind of borrowed word, but normally when you borrow a word into the language, again, you have to break it down to adapt to the morphological and the phonological pattern of the language. Normally, Yoruba words don't end with consonants. So you will always have a vowel insertion. So COVID normally has to be broken down to COVID or COVID-19. Well, for the naming, it continues on and on like that. One interesting name given to COVID-19 was the word corolla. Now, on the surface, this is derived from borrowing the word corona. Corolla seems similar, but actually it's different. The naming of COVID-19 as corolla, when I was trying to find out from those who named it corolla, they said it actually expresses how the pandemic only enriched the pockets of certain individuals or government officials. So the verb la means to profit in Yoruba. So when you say mola, you profit. So corolla, passing information across that COVID-19 actually was meant to profit some set of people. And of course, it's the truth. During the pandemic, a total national lockdown was declared. So the result was several job losses. Here's the next slide. Several job losses, massive economic losses, rampaging hunger in the land. During this period, the government of nations across the world distributed aid to people in the form of both food and non-food items. But in Nigeria, what do we find? The palliatives were cornered by certain individuals. The corolla therefore foregrounds how some officials profited from the pandemic. I'm sure for some of us who were around, a bag of rice could be given to like 2 or 3 streets. So you imagine 2 or 3 streets wanting or a local government to share 2 or 3 bags of rice. In return, each household will get one thing. So you can imagine that kind of palliative, quote and unquote. Meanwhile, millions, if not billions of naira was pumped into COVID, but some had cornered them up and then profited from. So that term actually foregrounds how some officials profited from pandemic. And then part of the naming strategies again, some named it COVID. And those are very minute, very tiny goods, poorly packaged palliatives given as cheap handouts to the masses. But the next slide. Some doubted the existence of COVID and saw it as a hoax that it never existed. And so some named COVID-19 as ironical. In other words, they believed COVID-19 is lie. It's just a lie. It never existed. So this again is further reinforced. If you look at that picture, that was exactly how the street of Africa was meant to be. But it never happened. We never saw dead bodies literally in the street of Africa. So people just felt, well, ironical. Bringing their views, their perceptions, and their kind of cultural dimensions, their opinion about COVID. Of course, health practitioners must begin to take notes and account of this. When people believe it's a lie, then they won't adhere to the prevention protocols. Then, again, during that lockdown, people were forced to remain at home. And what do we find? Increase in pregnancies. As these new babies were born, people humorously gave names as Korobi, Koromuiwa. So that was the gave names humorously, of course. No parents would call this guy Korobi or Koromuiwa, but people in the neighborhood, Korobi. In other words, COVID-19 brought this. This again is similar to the naming patterns in the culture of Yoruba. We name people after gods, Ogunbiyi, Ifabiyi, Eshubiyi, and so on and so forth. And then some for Christians, we say Oluwabiyi. Or instead, we now have Orobiyi, Orobiyi. Probably some of us, they have children that have new nicknames now. Orobiyi.
2 minutes to go.
Well, my time is almost up. But let me just round off with the concept of Obanikoro. Well, the name is a shortened. Obanikoro is a personal name, and of course, very popular here in Lagos. Ikorodu is a large city in the north eastern part of Lagos State, Nigeria. Now, when COVID-19 came, so that personal name of this of Obanikoro, I interacted with some, and then the opinion was, oh, Obanikoro. So it kind of play on what changing that concept to show that Obanikoro, meaning the king, has coronavirus. Now, in my interaction with some of them, I was asking, why would you suddenly change it to Obanikoro? Their opinion was that COVID is for the kings. Now, kings is used literally here for elites. The elites, the king, the ruler, the politician, and their belief was that COVID was actually imported into the country by the elites. Those who traveled out to the West, of course, they are the ones that brought down COVID. Well, I'm trying to wrap up. So because of that, the poor masses believe by taking salt, those who walk in the sun, walking in the sun from morning till evening, they can't contract COVID. And so when people say use face mask, people just disregard that. When you go to the market, talk about social distancing, you won't find it. You see them crowded because they believe COVID they make it. With the kind of sunny kind of work atmosphere, I'm walking under the sun, I take in salt, I take in whatever. So they believe COVID can't catch them. Well, in conclusion, there are so many, let me just keep them. In conclusion, what I discovered when I went to SG, the Center of Excellence in I was trying to find out of those who contracted COVID, is it just the elites? And then they told me, no. Poor people, the rich, the poor, the educated, the non-educated, the elite, non-elite, everybody contracted COVID. And so I want to conclude that, well, for health practitioners, it's not just enough to learn all the medicines. They must begin to look at the culture, the perceptions, the thoughts, the beliefs of the people. And that will help them to find more proactive ways to manage subsequent pandemics and diseases. Thank you.
Thank you very much. It was an interesting presentation. Is the online speaker still with us?
Yes.
Ọlọ́run Mowaji. Ọlọ́run Mowaji Ayọ̀délé. Are you with us?
Yes, good evening. I'm with you. Sorry, I joined a bit late because I have some technical challenge trying to get connected with the system, but not possible. So I have to use my phone. And at present, I don't know if I'll be able to share my slide.
Can you hear us?
Hello?
Hello?
Yes, I can hear you.
Okay. You have 15 minutes.
Okay, I said, sorry.
Hello?
All right. Yes.
You can start. We can hear you.
Is it possible for my slide to be shared from there?
Yes.
Yeah, it's possible.
I didn't get you.
It is possible. You can hear you.
Okay. Yeah, please. I made you, Sir Bankole. I sent my slide to you. I don't know if you can assist in sharing it over there. So I proceed from here.
So next speaker, Ọlọ́run Ọjọ́ Ayọ̀délé Ọbátómi, narratives of the performance art in advocating public health in Samaru, Zaria, Ahmadu Bello University. Are you ready?
Yes, I am.
Okay, so what's the name of
I am.
this slide?
Send it to Bank College. Send it to Bank College.
Yes.
Which email to send it to?
I'm typing it.
Your
It could be in the email.
no, not your Gmail, not your Gmail.
Okay.
So,
I think the institutional.
Olorumowaju. You know
Yes,
what
Prof,
you
sir.
want? Kindly check that email
No.
that's been sent to the chat, and email the PowerPoint there. So that will be set up and then you present after.
Yes, that's the email I sent to.
Yes. So that's
Olorumowaju, as we're waiting for you,
Yes.
okay. Dr. Kudus Adebayo. Okay, maybe you should sort of waiting. Okay, as we are waiting for Olorumowaju, Dr. Kudus Adebayo will be our next speaker.
Yeah, so good evening, everyone. So this paper is titled Social Construct of Care and Interpretations of Hospital-Based Informal Caregiving in Southwest Nigeria. Now, a bit of background. I'm presenting this paper alongside my colleague, Mofishara Oluwatoyin Omobowale. She's here. Please wave. Let them see you. So in case there are questions I'm unable to answer, she will gladly respond. So a bit of background to this work. I'll let you know when you need to go to the next slide, please. Stay on the first. Stay on the first. Yeah. And could you project fully? Slideshow. Yeah. So a bit of background. Back in 2018, where this research came from, I was caring for someone at the public health facility in Ibadan, and it sort of happened that unplanned. It was unplanned, and the person had to stay overnight at this tertiary health facility. And what happened next was at midnight, because there's no place to sleep, you're just hanging on like iron benches and all of that, and then you go out, walking around the compound, just getting air, in the midnight, and then you see people all over the place with mosquito nets, you see beds, you see mattresses, you see people hanging, in different places. And the realization came that in hospital facility, particularly tertiary health facilities in Nigeria, there's a lot of invisibilities associated with caring that had not been properly documented. In fact, the realization was also that it's so common, it's such a common phenomenon that people are so used to it, the healthcare professionals are used to it, the patients who bring people are also sort of used to it, that is not being talked about as one of those very critical unpaid labor. And the fact that even our healthcare facilities could easily become a space of suffering for people who actually support hospitalized patients. So that this research that we're presenting was funded by Consortium for Advanced Research in Africa. We did it for a year in 2023. and I've published some things around it. So this aspect of the work is basically just trying to look at the kind of construction of care that emerged from this kind of like support that people give in the healthcare facility. So in terms of the content of our work, we had a brief of the background that we're going to be talking about. The key question that we explored in this particular presentation, and a bit about our methodology. So we are also going to be sharing the broader methodology that shaped the work, and also in doing that, to point you to the fact that all the most of the pictures you are seeing, I think except from the one on the background page, were actually taken by participants who were in the study. Because what we also did was to get them to participate in photo voice. And that means, they collecting pictures about their experience, within the health facility. So in terms of background, we noted that African health system faced strain due to resource limitations, and that in the context of these resource limitations, relatives often provide hospital-based care due to even nurse shortages. We know the phenomenon of JAPA, a lot of people are leaving. So their care process in terms of human resource is actually very limited. So in providing this support for hospitalization, informal caregivers, though invisible, remains very critical. But the experience of this hospital-based informal caregiver has not been sufficiently examined. But beyond that, we also know very little about how those who provide this supportive care construct and subjectively interpret their informal caregiving experiences, while caring for their relatives who are hospitalized. So the key question that we raise in this particular paper is what meanings do caregivers assign to hospital-based informal caregiving, and how do they interpret their roles and experiences? Methodology-wise, go to the next slide. So I was talking about we are publishing some part of the research, and you can see the very first one on the right-hand side, which essentially is looking at the routine, related to providing this care. What do people do when they wake up in the morning? How does their day start? So we try to follow them up. We did overnight ethnography to also be able to capture those experiences. And the second one looked at the challenges and consequences of hospital-based informal caregiving, where we are just trying to track how does this supportive care impact on the caregiver. And you can see there, a person taking care of the sick is also sick. So the work, as I mentioned in the beginning, is an ethnographic study based within the health care facility. For the study, also, we interviewed 21 informal caregivers. Of course, there are different categories of participants in this and the broader work. We talked to patients, about 15 of them, and some were actually paired with informal caregivers. So we interviewed informal caregivers and some of the people that they were taking care of, and also conducted interviews with healthcare providers, doctors, nurses, and also the management. So I think the bigger study, we had about 75 or thereabouts participants in the work. But most of what we present in this particular paper focused essentially on the 21 informal caregivers who were involved in the study, and also from whom we picked the 5 people that participated in the photo voice activities. We also particularly focused on caregivers, informal caregivers residing in and around the health facility. So the broader idea is to focus on those who we called migrating informal caregivers. And by migrating informal caregivers, we're talking about people who leave their normal place of residence, to provide hospitalization care for relatives who are within tertiary health facility. So we look essentially at people who are being supporting people on admission at least in the last 3 days or so. They have spent at least 3 days within the health facility, and then conducted observation in the morning, afternoon, and night, just looking at how people move around, what their experiences have been, and all of that, and conducted interviews using, and then the analysis was done thematically, and also we also did interpretative analysis with the aid of in vivo software. Now, some of the key ideas that emerged from our work, the first has to do, in terms of construction of care, the first has to do with familism and relational positionality. Now, these informal caregivers see themselves as naturally suited, to support hospitalized relatives. So we basically had people who felt that if they are not there, the care will be inadequate, in a way. So, and they perceive suitability to care despite the inconveniences related to hospitalization support. So you hear phrases like oju oloju, olejo oju eni, that only a family member can care sincerely, within this healthcare setting, despite the inconveniences associated with it. And you can see some of the quotes that on the right side about this female 63-year-old woman who was talking about that she can't joke with a child, and this is why she came to stay with her. And another person also talked about this familism, a child being cared for. Another point that jumped at us is also care solidarity. The notion of iduroti or aduroti, as some will say. So care solidarity is a persistent perception as reflected in Yoruba norm of care, and then standing by, in their sense, in their mind, is simply to care, to duroti, and this particular observation seems to underlie the significance of familial presence or presences as we have it in hospitalization care process. So the proximity, being there to the person who needs assistance, even when you don't have the resources, to support them. So we had people who felt that they didn't have money and all of that, but being around us is a very critical part of that care process, particularly for people who are facing very difficult process during the time of illness. And as you can see here, some of the people quoted saying that not having a good person to stay with them renders money useless. So this notion that even when you have money, you have the resource to receive care and all of that, if someone is not there, monitoring, providing social support, providing giving you a sense of feeling that you are not alone, seem to be a very critical consideration. So the person we can call family, of course, you see this the notion of iduroti also being connected to familism, the idea that only the person who can stay with someone in difficult time is actually a family. Another interpretation. So here, the first two conversation is about the care construction that came out from the interviews that we conducted. So, but here we are talking about interpretations that people bring in terms of their experiences, within this healthcare facility. So the first one having to do with the notion that hospital, as an inhospitable space. So where the idea that a place that is supposed to be a place of care, a place of recovery, a place of healing, easily becomes a place where people face significant troubles when it comes to healing. So there we are talking about how presence for care is uneasy and fraught with significant difficulty, where hospital is also interpreted as hostile, and not a home. So there's so if you talk to some of you that we talk to, they will say things like, "Oh, this is not my house. This is not my house," so that they could understand why the environment is a suffering space. So that distinction was being made. So, and here you can see that picture there taken as part of the photo voice. That's typical place that someone would sleep, and then you see the paper. So the carton is something to support the body while lying on this very iron surface. The last major interpretation that emerged, it has to do with discomfort. Now, there's discomfort particularly related to the notion of inera. So when they're talking about their experience within the health facility, this participant was talking about how praying that may God not let us experience discomfort again, may I never see this again. This idea that within this tertiary health facility space, and you can see the building, where a lot of times people have to walk multiple times, up and down the stairs to do tests, to collect test results, to do all kinds of things, just moving around, these care mobilities, which we are looking at in another paper, but it's framed as INERA. And you also see this narration around TUBU, the idea that the health facility is prison-like, which also brings the notion of health system as a total institution, from the sociological theorizing point of view. So someone will say that it's just like I'm in a prison, like I'm locked up. And this ground that is typically unkept, is where people will spread their clothing, not just theirs, but also that of the patients, that they are caring for. So which also typically exposes people to serious challenges. And you can see an assertion from someone, Tubu Gidi Reo, this is an authentic imprisonment. There's also EGMI, filthy treatment, the way they are treated, when they engage with healthcare professional within the health facility, the nurses, especially, in terms of how they relate with them, where they stay, where they're unable to stay, when they can see a patient, how they use the word or not use the word, the way they also relate to them when certain responsibilities are requested related to testing, collecting results, payments, and all of those other experiences. So what do we make of this? Essentially, we see a contest between cultural expectations versus institutional limitations, taking place within this tertiary health facility space where caregiving and support, has become an experience of suffering, for family caregivers who support their relatives who are on the sick bed. And also, these caregivers experience hospital-based caregiving as discomforting emotionally, physically, financially, and socially in many ways. And these experiences are grounded, subjectively in many ways, and reveals the psychological distress associated with providing hospital-based caregiving support for their loved ones. And then, of course, we see this emerging as TUBU, or the notion of INERA or EGMI, that's been experienced, by people who provide.
Caregivers hold the health system together in many ways, where there's a crisis for human resource for health. People who provide this care, particularly during hospitalization, hold the health system together.
Are invisibilized and undervalued within this caregiving space. And of course, should typically shape the way we try to reform the health system. And there's need for us to rethink the design and ethics of hospital-based care giving to support caregivers assisting their relatives. So with that, I'd like to say thank you for listening. And then thanks to the funders, to the organizers of this panel. Thank you. Yep.
Thank you, Dr. Adebayo. Before we move to the next speaker, is the next speaker ready? Okay, before we move to the next speaker, I think your work aligns with that of the late psychiatrist and former UIVC, Thomas Lambo. So when he returned from Europe, so he discovered that mental patients that receive treatment with their family members, and they got it better, like they performed better than the one staying alone. So we have to look at our cultural backgrounds in Africa. We are communal by nature, unlike what is obtainable in Europe. So we stay with your family, so they were performing better. And WHO in Geneva borrowed his template, and he later become their deputy director for 70 years, Thomas Lambo. Brilliant presentation. Thank you. The next speaker, are you ready?
Yes, I am.
Okay.
Yes, I am.
We can hear you.
Okay, can I go on?
Go ahead.
Okay, thank you so much. I want to appreciate you for giving me this opportunity to present and for receiving my slides through the mail to assist in getting it.
Sorry. Is the slide ready?
Right, the topic says,
No, it's not corrupt.
oh,
It's not corrupt. Let's just
I think the slide is there. I can see it.
yeah.
Go ahead, please.
Can I go on? All right, thank you so much.
Yes.
Sorry for the hitches. All right, narrative of performance arts in advancing public health in Samaru, Zaria. Samaru is a suburb in Zaria City, where we have a place mostly dominated by students because we have higher educational colleges around APU, for instance, Ahmadu Bello University Zaria. We have the Nigeria Institute of Leather Research, the NILES also, and the teaching hospital is not far away from it. My name is Obatomi Olorunwaju Ayodele, and performance well-being. Please, let's move to the next slide. Performance well-being is an issue that is needed to be treated in the society. Arts for the heart. Please, the next slide.
I think it's just continue. Please continue.
Tell him to go on.
We just keep presenting. Should he has a slide? Can you present without your slide? Go ahead, please.
To keep beating. Please, the next slide.
Continue, please.
All right, thank you. Now, the public space. Yes, thank you. Yes.
Would you please, is it possible for you to present without your slide? Time is not on our side, please.
Without my slide, without my slide
Just
from
go
your
ahead,
place.
please. Yes. We can hear you, please.
All right. Okay. All right, thank you. The public space actually speaks about the promotion of communal health being for all, disease prevention, how to prolong healthy lifestyle through mobilization efforts. Now, the emphasis of the public health space is an emphasis for the populace and not for an individual. And so our focus in this research is how to promote availability of blood in the blood bank for healthy use at no expense of the end users. Through performances, we have treated issues of all. We have campaigned, mobilized, and conscientized people on issues like mental health and to kick against abuse. But in this presentation, our focus is on the campaign of an increase in the pool of blood in the clinics through the arts of performances. Knowing fully well that blood is something that is needed in every society by lots of people, either by accident victims, anemic patients, or by pregnant women too. Now, we've come to understand that from researches, both by scholars and from our own engagements at the clinics, there are dearths of blood, availability of blood, safe blood in public health centers in the clinic. In 2021, I visited the Ahmadu Bello Teaching Hospital for a blood donation as a replaced donor. And while there, I saw a gentleman suffering, and he was embarrassed by the question or by the instruction to get a donor because his wife is due for delivery and he needed 2 kinds of blood. And I look at the man, he was so fine, someone that's, literally he has no money even to pay for the blood. And with that, I asked the nurse that aside from coming here because it's far away from the town, from Samaru, that if we engage in public campaign, would they come out to receive blood for the blood bank? And they said, go ahead. So that marks the genesis of this project. Now, the World Health Organization has projected that sub-Saharan Africa should be able to overcome the issue of that of blood in their blood bank by having a sustainable blood transfusion for everyone. Now, but even as at 2014 and 2017, researchers have confirmed that Nigeria have not been able to meet this expectation. Why? Because out of the 3 classes of blood donors which we have, the voluntary donors, the family replacement donors, and the paid or commercial donors, that the paid or commercial donors seems to be of all the commercial donors, the paid or the commercial donors. Thank you. And from statistics, the paid or the commercial donors do not have or donate safe blood because they are after the money. Now, why do we have that of blood in the blood bank? Some of the reasons could be because of mythical beliefs, largely due to ignorance. It could also be due to cultural values. Some people do not believe in, how will I put it, blood transfusion, like some religious creeds does. And with this, we maximize on the aspect of ignorance, because being somehow situated in a youthful environment where we have mostly populated by students, we believe that education will go a long way to be able to conscientize people and make them to make up their mind to be voluntary blood donors to save life. If this is not attacked quickly, certainly is going to have a devastating effect on the disadvantage in the society, where blood is so where the blood bank is empty. Certainly, people will pay high amounts of money to get blood for transfusion. So the aim of this is to organize a campaign, successful campaign for blood donation through entertainment, education, concerts, in order to counter the erroneous entrenched belief system from the minds of lots of people, in order to reorientate them, inspire them, and convince multitudes to join the pool of voluntary blood donation in the university community, and also make blood available and make safe and healthy blood available for clinics. We are working with the entertainment education theory by Miguel Sabido, and we believe that entertainment is a youthful culture and something that can arrest the mind of youth, attract them. So via entertainment of sound, musical entertainment, as we had in 2021, seeing the peaks here. We believe that sound attracts youth, quality sound attracts youth, and having them involved in this entertainment culture is a platform that the society has given. So we got talented stars, so to say, budding stars on campus, train them, inform them on the need for this campaign, a free this thing, and they signed the consent form. So we went ahead after a series of practice. We had the first concert at the basketball pitch, and it was a successful one. Now, this is not done by the arts alone, but also in partnership with the health personnel from the clinic. Knowing that this is a public health campaign, ours is just to provide the platform of engagement via entertainment to instruct dramatic pieces, spoken words, and also musical performances. Then we pave way for the vast clinical staff to come in, conscientize them just briefly within 5-10 minutes, and invite people who want to freely donate blood to go. Now, this idea also is that a lot of people have phobia with blood or with pins. And so what we did is that as the beat keeps going, they keep donating. As the donation is ongoing, performance is ongoing. So in that way, sound tends to suppress the fear in them or the anxiety in them, and they are freely moved to donate. In the last edition, 2024, it happens that some of the performers, those who performed, the artists on stage, immediately they went straight to the blood drive stand and also donated. So from 2021, where we started, we focused on Ahmadu Bello University on June 14, and 2022, during the strike, we could not hold it at the university. So we take a leave or a step further and move to the Nigeria Institute of Learning Science and Technology Research. And it was also successful. 2024, back to Ahmadu Bello University, and 2025, we are planning to host it ending of July. We couldn't hold it at the normal time because students were on break. Now, to be sure that ignorance is one of the challenge we have for people not to donate. In our little survey, we asked if people have donated blood before. Among those, because they have to fill the consent form and attend to a few questions in the questionnaire. Now you see that about 92% of the donors had not donated blood before. And so, but they donated. Now, having done that, we went further to probe them. Would they be willing to enroll into the free voluntary blood donors and to donate also? And we can see that 84% of the donors are willing. Therefore, it is glaring that the public space presents us an avenue to be able to treat public health matters if well utilized. And art is a good instrument for that. The call is for everyone. This is the band. The call is for everyone because this is a big. There's still that of availability of blood in the blood bank. So far, so good. In most of night concerts, because it's just within short duration due to security issue in the north, we are not supposed to have more than 2-3 hours engagement. So far, so good. The health personnel are be able to successfully bleed at a goal, not less than 25 volunteers. And so far, we'll be able to screen people because the process also is not just to it's not just to harvest the blood, so to say, or to get the blood donated, but also it's an avenue to screen people of diseases like hepatitis and also HIV. And for the donors who volunteered, for those who have issues with hepatitis, maybe they have detection of the element in them, they stand the opportunity of being vaccinated freely, and we'll be able to follow that. In our success results so far, we've been able to have about 85 blood donated successfully to the University Health Services. And this year, we hope that we'll be able to get more than 50 volunteers. At present, we have started the publicity online. And even before the actual date, people have shown interest. And some also have been directed.
You have 5 minutes. 5 minutes to
Thank
go,
you.
please.
Thank you. I'll round up before that. And some have been directed to the clinic for blood donation. So I would like to conclude that there is high demand for safe blood in our clinics daily, and this can only be met by conscientious effort of both the public, the health personnel, and everyone. So the art remains a valuable instrument for engagement in public space for the well-being of the community. Therefore, constant engagement of performance art should be encouraged and should be supported to address the issue of public health in our community. Thank you so much.
Thank you so much, Ayodele Obatolu. Now it's time to welcome
Thank you,
comments,
sir.
questions. Comments, questions. Okay, let me start from your name, please, and your institution.
Okay. For submission from OAG. So, as I said earlier, I will be addressing the first speaker. It's not going to be like a question, just suggestion on what the students explain. You were using language planning as your theoretical foundation. What I have observed so far is that you are staying on one of the aspects of language planning, which is organization, how the virus has helped us to coin new lexes. But the other aspect of language planning have been slightly neglected: graphization, codification, standardization, and so on. When we have a lexicon, corona, you did not tell us if the item should be treated as a noun, a verb, and so other aspects that should be accounted for. And also, there is no way we talk about language planning that will not talk about language policy. I think the study should involve how the policy of Nigerian government should promote or should help in standardizing these words. And lastly, you only use 2 lexicons so far, and they are Coro and COVID, which you sum up as affixes to all other words that you've coined. So I think we should look more for new words. And to the second speaker, I have issue with translations of the word Subu. You are not consistent with your interpretation. In an aspect, you revise as prison, and in the same particular sentence, you call it imprisonment. So I want to be sure which one of the 2 we are to pick, or we should just maintain one. Thank you.
Thank you. That first will be for
Your name, sir.
my name is Kingsley Lugan, Corporate Department of Political Science.
As far as
So, Dr. Burundi, thank you for that wonderful presentation. Just for currency,
SG has changed to Institute of Genomics and Global Health. So maybe in your write-up can always be referred to as formerly SG, and then you state the current name. Few things here, let me rush through them. One is that there might be need to involve some sort of media representation, majorly in terms of Yoruba-based newspaper like Alaroye or something, to further strengthen how those words, came out in their reportage during the COVID-19. If we had some of the maybe screenshots of those headlines and how it was used, I think it would have given more strength to what we have. The other thing is that on the aspect of Corolla, that is the profiteering from coronavirus, I would suggest that you extend it a little bit, maybe to the international scene, to begin to talk about how businesses, especially pharmaceutical companies, during coronavirus, pack of face masks that we are buying for 1.5 skyrocketed to almost 20,000 naira. Same thing for gloves and so many other hospital equipment and supplies. And also, it was during that period that most pharmacy companies, recorded record high profits, vaccines and all of that. So you can find a way of bringing all of this into it. And then lastly, for you, sir, is that in the course of your presentation, you said you were able to deduce, maybe at the level of SG, that those who contracted COVID-19 got across different socio-economic classes. And I'm afraid that considering the protocol of testing, SG might not be the best place. In terms of, SG is a lab, is a genomics lab. And if I could remember that protocol then, there was an announcement that if you feel this symptom, feel that symptom, let the hospital people come and test you. So they pick the test, they pick the sample and take it to SG. So SG might not be in the best position because they might not have the whole social demographic information behind every sample, or rather the healthcare professionals who go to this symptomatic patient to pick up those tests might be in a better position to decipher if truly it goes across. Then to my Oga, I think it would be very important to conceptualize in a way of distinguishing between caregivers and patient relative. I work with a teaching hospital, and I know the role that patient relative play. To a very large extent, you see them almost taking up all of these that we have described as the roles of caregivers. But in my own simple understanding, I would look at caregivers as even more than what a patient relative would do in terms of being involved in giving medication, being involved in dating, feeding, and all of that. So it might be important to properly contextualize so that we can know, yes, informal caregivers, we can know what exactly you are looking at, and that would inform your selection criteria. And basically that. And again, to that paper, is that I was also thinking that if it's possible to advocate beyond improving the design for the life of caregivers, yeah, I said patient relative, to begin to rethink the Nigerian health system, whereby I'm a working class person, my wife is sick, I can call the ambulance or take my wife to the hospital, and I can go back to my work, and then all of the care can be provided. We need to take it beyond, me as the husband being able to stay there for the period and all of that. So it will be important to have such a system that care can be provided independently of either the patient relative or the caregiver. And finally, how does the description of the study? Okay, because I said overlap and all of that. So
I think I've mixed things up here, but we can discuss afterwards.
Next topic on
Chairman. Okay, thank you very much. I really enjoyed his presentation, all the presenters. But I am wondering, do you mean contracts or contacts? I was wondering. Then, did you bother to investigate or examine why people have seen that it is organic or that it's not for the masses? So, did you check that? Thank you. Okay. Good afternoon, everyone. Thanks to the presenters for the amazing presentations. So I have a question to the second presenter. So I really enjoyed your presentation and the insights that were shared too. So I have a question that says, like, how do gender roles and family structures influence who provides and receives informal care? Okay, so well, I would like to add something. Like to add something to that. Okay, so in 2000 and I'm sorry, I'm trying to remember, 2017. So I had an accident and I was on transit to another place. So I was hospitalized at Kogi State, I think, teaching hospital at Lokoja. So at that point in time, my parents, so it's more like I did not know how they made that decision, but my mom, she became, I won't say caregiver, but she's family. So and I watched how every morning she's not allowed to sleep in that ward. So every morning she go outside. I think it was for like a month. So every morning she sleeps outside. It was when I was able to move, they were able to carry me outside, and I got to know that she was actually sleeping on bench, and it was not a favorable, like, even after we left the hospital, she wasn't feeling too well, like, you understand. So I don't know how they made to make that decision that, okay, it's my mom that should stay behind. That was why I asked, like, what influences do you get to ask this correspondent that, okay, how, because I know a number, let me say like 80 or 90% of these correspondents are women. Yes. And I think also when I went to UCH, I saw a lot of women that stays around the vicinity in the night to care for people too. So that's just my question.
Thank you very much. Please,
Thank you very much. My name is Oluwaseun from the University of Plymouth, and my question, Plymouth, United Kingdom. Yeah, my question goes to first Dr. Olojide. He talked about the Yoruba people trying to come up with a collection of coinages, Koro, this, Koro, that. Does it speak to the class distinction, like what's common among the non-elites or the elites? Who are these Yoruba people? You just said Yoruba people. Then, secondly, who are your respondents? You said you interviewed some people online, some people on the streets, and went to Aegis. So who are the respondents? But if you look at it, your conclusion says Aegis says, both elites and non-elites contracted COVID. So they have spoken to the non-elites, and they said no, COVID does not exist. So it appears to me that it's not probably your sample was not representative of the larger population of non-elites. So I think you should speak to or respond to my question. Thank you.
Good evening, everyone. My name is Basura Tadepile from University of Uyo. My name is Basura Tadepile from University of Uyo. I heard Corolla. Is it Corolla or Corolla that is being which one out of the two, sir? Because I have a comment on it. Corolla. If it's Corolla, it cannot be Corolla because we have that nasal sound present in our language already. So we cannot alternate it since it's present. We all know that when borrowing word, we have to incorporate it into that existing style of writing. But we have the nasal sound, we have it is present, so it should be corona, not corona. Thank you.
Thank
Thank you so much. My name is Matthew Aidele from Stanford University. My question is to the second speaker. And first, thank you for your work. But the first question is, how does your work challenge or expand existing, studies on king-based informal care system? And the second question is just thinking beyond immediate family care. How do we also think about economic performance of distant relatives? So I know of, I don't know if you're familiar with the work of Julie Livingstone, who did a work on debility and morality in Botswana. And she looked at how informal care system actually goes beyond immediate, family, but also people that gives family money to take care of, the sick person. So it's like a broad network of, informal care system. So I don't know if you kind of see that same pattern in your research. Thank you.
Thank you. The next question should be directed to us. I'm worried. Yeah, we are having a situation. Okay, performance stance in this context, does it have to do with exercise? Are you with me? Hello?
I think it's talking about entertainment.
Entertainment.
Who plays, really tell people about, and then you conscientize people by doing a play, doing a song, just like what we have today.
Okay.
That kind of performance. Now about conscientize people about the benefit of doing this. That if you do this, it's benefit you can derive from. And you do that, and then you get more people, who plays, like just 90 won't do. If it's told by drugs.
Sorry, I was muted.
When there's a performance around it, then the people are
Sorry, I was muted.
Oh,
So you have a question for the third presenter.
good. I'm happy. Someone has a question for you.
It's not all about exercise. It's performance.
Yes,
It's performance to conscientize the people, to
Your
entertain the
question,
people, and to educate them.
Okay. Your question?
My question is this. But thanks. While you're advocating or making us to see how performance can, where is it? Now, there's something in social sciences, we call it the interrupted time series. And what that form of analysis does is to be able to show us what the situation was before this intervention. So the moment this intervention comes in, we can easily measure the changes. So it will be interesting to know how you've been able to integrate a form of measurement to really see that what you are suggesting or advocating can or has really brought about some changes in terms of public health updates. Did you get that, sir?
Okay. Yes, sir. Thank you.
In advance, thank you.
You need to.
Okay.
response.
So I am not actually a part of this panel. I'm not in the public speak, but as an interdisciplinary researcher. So to the speaker, while you were doing your slide, I saw that the okay.
Are you with us?
I'm with you.
Okay.
Yes, so I'm with you.
Okay, so while you were doing your slide the other time, I saw that you showed existing studies, existing like some of it that has been practiced in some countries, and but then I saw that there was an existing gap in Nigeria. And if there is an existing gap in Nigeria, then that means there will be environmental variables, there will be socioeconomic variables, and there will also be political variables that are impacting the existence of this particular thing that you are advocating for. You cannot advocate a problem, a solution to us without telling us the problem. So I feel that have you, to an extent, try to understand the problems surrounding the non-existence of what you're advocating before you advocate it to us. And in that extent, too, I'm going to link my question to what our doctor said here. Have you tried to measure or have you tried to check out the potency of what you are suggesting to us as a whole? Thank you very much.
All right, thank you. And so let me attempt to both questions and that triggers from the presentation. Looking at what the environmental challenges, political challenges, or religious challenges within. The focus here is on Samaru here. Just like we said, from 2021 and now, from our engagement and from our on-field research and encounter, we observe that the aspect of public enlightenment is actually the major gap. In 2022, when we went through the community leaders, because it was actually at Samaru town. So we went to the community leaders and to see how their religious belief, how also their political setting permits this or not. And also in line with the council, with the council, there's councillors within the terrain, the Samaru region, for instance. We went through and presented all this. It was a welcome idea. But just like we said, from this thing, our finding is that the idea of conscientization of the people has not been there. There has not been enough mobilization in this aspect. And if I may even ask, both those of us at this panel, if I may ask, how many of us have freely volunteered to donate blood? You see that, we see some of us who do not see a need for it. But just like somebody shared there, why you had accident, peradventure, let's say there's need of blood, then who would have donated to you? You didn't need to call your parents from afar to come and assist you at Kogi State. So it is a communal effort, it's a communal need, and that's the essence of public health, to see how the community can mobilize itself. So within this environment, we observe that there has not been enough enlightenment because it's a student environment, and that's why we maximize on this and we are pushing forward on it. Thank you.
Thank you, Abatumi. Thank you very much. Another question.
Hello, are we together?
Okay, your question. Oh, sorry.
Thank you very much. I have a number of questions, but of course, for the sake of time, I will not be able to respond to all. I appreciate some of the feedbacks. I'm going to work on them. But on some few, one, you contract a disease, don't contact a disease. You can Google check if that is what we got. You contract a disease. You contact individuals with it, but you don't contact disease, you contract disease. Then on I think on my methodology, well, like I said, I had both quantitative and qualitative. The questionnaire I administered was actually spread across the entire Southwest. There was no time I would have shown the breakdown. I did the statistics across different strata, educational status, financial status, ages, and the rest. It's actually spread across different people. Then those who I believe can't really, of course, when you talk about the non-elite, they can't deal with Google Forms and the rest. So I went to the market and then reached out and administered them physically. Well, I think Another aspect, I think I've taken note of that. I'm going to work on them. Those that were asked to me. Thank you very much.
Yeah. So, okay. Thank you all for your interventions. The points noted by Tosi, we've highlighted that. I think the should be this is real authentic present. That has been noted. Caregivers, patient relatives. Absolutely. If you look at the paper that we mentioned on, I'm the one caring for and donating blood. One of the very first paper that we published from the work, tracks the routine, but also the role that informal caregivers play. And within all of this, a lot of the questions that you raised would have been answered in terms of the range of things that they do. So it's very comprehensive. It is persistent and without break, in this context that we did this research. And in terms of advocating beyond design for support, why should you be there and all of that? We also realized, I'm talking to this because we did like a broader study, so we couldn't put everything in this particular paper. Some initiatives were on the ground. We had the helpers initiative and all of that. But we also observe, that it's raised a question about health inequalities. Who can afford it because they paid work, and a lot of people that go to these tertiary health facilities are actually poor and did not have the money, financial resources to be able to hire these people. And even the helpers, so-called helpers that participate in this kind of support. That participate in this kind of support also face similar challenges, So if they are staying overnight, for instance, they also don't sleep. And that's part of what we also observe. And then in terms of the gender role, how it shaped care, this is also still connected to this issue of work, who gets to go to work, who gets to bring the money, who gets to support. And we also see that a lot of actually elderly women, provide this kind of support, which raises a lot of issues around healthy aging and how caregiving, co-opts people who are supposed to be resting, into the care process, that is also based on utility and value, that they perform. Just institutional violence, if you want to think about it in that way. And how does it challenge the existing study of kin-based care? Absolutely. We are working on a theoretical paper, just trying to frame, map care mobilities and associated factors that drive the participation in hospital-based informal care. And a lot of these explanations, would easily come up in terms of kin-based care, being co-opted as a result of like this. So we have this conflict between cultural beliefs and then assumptions associated with who gets to provide care within the health facility. So you see the health facility co-opting, this kinship system, co-opting into use, for people within the healthcare setting while not paying, for that co-option. So it's part of like these theoretical issues that we're trying to deal with that paper. And the economic performance of distant relatives, of course, absolutely. Those who are based or who are on the ground raise money for those who are unavailable, to support this care. And because a lot of people are paying out of pocket, there's also this catastrophic expense that comes with providing support to hospitalized relatives. But we take all your comments and with as much as possible. Thank you, Jen.
Thank you very much. Thank you, everyone. Thank you. Thank you. And we still have 3, 4, or 5 that one session of this. Please join us tomorrow and next tomorrow.